Zawar. He is medical oncologist at Aurangabad and he is present in person here.
Good morning, everyone. I'll be presenting the Keynote 598 study, which was published in JCO by Dr. Michael Boyer. It is a study of pembrolizumab given with ipilimumab or placebo in participants with untreated metastatic NSCLC. So the background of the study was, as in the previous discussion we had, based on Keynote 24, Pembro monotherapy is the standard of care in NACLC with TPS more than 50%. Despite this effectiveness of Pembro monotherapy, still there are 50% of the patients who die within 2 years. Hence, we need to look out for more effective therapy. In fact, in this study, Keynote 24, after 2 approximately died. So looking at the favorable data on the first line single agent immunotherapy in PD-L1 high patients, a question has arose as to whether have been continuously made to combine these drugs to leverage the different and potentially synergistic mechanism to improve the patient outcomes. So, and dual immunotherapy constitutes a standard of care in other advanced malignancies such as melanoma, RCC, and we have the result of Checkmate 227, which showed that first-line Nivo plus EP significantly prolongs the OS in comparison with chemotherapy in patients with NACLC with PDL1 more than 1%. The purpose of this study was to determine the efficacy of both Pembro plus EP versus Pembro with placebo. So the hypothesis was that OS and PFS is prolonged in patients who received IO-IO combination. So the inclusion criteria were histologically confirmed. Histologically confirmed diagnosis of stage 4 metastatic NSCLC, measurable disease as per iRECIST, ECOG PS0 or 1, life expectancy of at least 3 months, and archival tissue sample or newly obtained core or excisional biopsy, not previously irradiated. Exclusion criteria were prior systemic chemotherapy or targeted or biological agents. They should not have EGFR, ALK or ROS rearrangements. Previous radiotherapy, known untreated CNS mets, and active autoimmune disease received steroids in the past 2 years. So this is a double-blind, placebo-controlled, randomized phase 3 study. So as we can see, the patients with untreated stage 4 NACLC, ECOG 01, no actionable mutation, PDL1 more than 50% as assessed by IC22C3 Pharma DX study assay, and they were stratified based on stratified on PS, histology, and region. So the arm A, the intervention arm, received 200 milligram per every 3 weeks for at least 35 doses, plus EP 1 milligram every 6 weeks for at least 18 doses. The number were 284 in both the arms, and the primary endpoint was OS PFS as per RECIST, and the key endpoints, secondary endpoints were overall response rate and the duration of response. So as we can see that the baseline characteristics were matched in both the groups almost. The median age was 65 years, approximately 90% of them were smokers. 1/4 of the patients were squamous cell, and approximately 3/4 of our histology was non-squamous histology. So the planned interim analysis was at approximately 255 deaths and approximately 12 months after the last participant was randomly assigned. Non-binding futility criteria at first interim analysis were difference in the restricted mean RMST, restricted mean survival time between EP plus Pembro and placebo plus Pembro at less than minus 0.2 at the maximum observation time and 24 months of follow-up. So OS and PFS, there was no difference in endpoint. As we can clearly see, the median OS was 21.4 in the Pembro EP arm versus the Pembro placebo 21.9. The 12 months survival percentage was 63% versus 67, and the RMST difference was in both at 24 months and at maximum time. It was minus 0.5, just crossing the futility barrier. So we have here the median PFS also, the 8.2 months versus 8.4, hazard ratio of 1.06. So we can see this, both the curves are not separated exactly on top of each other. And so there was no difference in OS, neither PFS. And similarly in response rate, overall response rate was 45.4 months in both the 45.4 percentage, both the arms. And also the best response rate is also the similar. And now, in contrast to the overall response, PFS, everything, but in contrast, we have the safety wherein there is more toxicity with combination, all in treatment related, immune mediated. Any grade toxicities were 76% in the intervention arm versus 68%. If we take more than grade 3, there was 35% in the treatment related in the intervention arm versus 19.6. Even if we take the immune mediated, it was more in the intervention arm, and the adverse events leading to death were 2.5 in the treatment related intervention in treatment related to adverse events, 2.5 versus 0 in the pembro plus placebo arm. So, and the most common side effects were seen was pruritus, rash, diarrhea. So coming to the discussion, OS and PFS outcomes observed with EP plus Pembro were comparable to those reported for EP plus Pembro in Checkmate 227, as we have seen. Likewise, the efficacy of Pembro monotherapy was similar across the Keynote 598 and Keynote 24. So it was neither Pembro did extraordinarily well, neither the EP Pembro combination did worse. It was that both the drugs behaved similarly as we have seen in the previous study. So why did we have negative findings? So probably dual immunotherapy may not work in PD-L1 expression more than 50% because the condition for immune checkpoints are already optimized. CTLA4 blockage will not add to the high level of pre-activated CD8 positive T cells in the immune microenvironment. Hence, additional CTLA4 blockage may not bring any clinical benefit as expected. Another bit of evidence to support the findings of Keynote 598 is the Checkmate 227, in which a group of patients with the very lowest TPS, less than 1%, had actually the highest and the most positive hazard. So basically, we tumor proportion score greater than 50%. There is no value in addition of EP to Pembro. It just adds side effect without any effectiveness. Pembro monotherapy remains the standard of care for this group of patients. Thank you for the organizing team to giving me this opportunity. Thank you.
Thanks, Abhinav. So we'll move on